like to welcome everyone to the KeraClub 2020. Next slide. These are the disclosures for the event. Next slide. I'd like to acknowledge Keratoconus Australia and the President Larry Kornhauser, who's had a really important role in supporting the KeraClub every year. We'd just like to let you know that the club is still active and can be, Keratoconus Australia is still active and can be contacted, and they're still continuing their work during the pandemic. Next slide, please. Now I have the pleasure of introducing Michelle Pritchard. Since childhood, her dream was to have a family and to be a concert violinist. But in the second last year of high school, age 16, she developed keratoconus. And then while studying at the Conservatorium of Music, her condition started to worsen, and this led to her having a series of procedures for the keratoconus, including 3 corneal transplants, while she also raised children over a 6-year period. With her vision improved from the procedures and contact lenses, she then got back into music and completed her studies at the University of Tasmania. She's performed as a soloist, a chamber instrumentalist, toured Europe, and become a teacher inspiring others. She's established a concert series in Sydney and in Eisteddfod in regional New South Wales. She's recently travelled to the Netherlands, where she is now, to undertake her Masters in Classical Music and Viola at the Royal Conservatory in The Hague. She reflects that her sight was taken away through the keratoconus, but then restored, and that gave her a second chance at music. And tonight she's going to host the KeraClub, and I hope it helps patients and their carers with keratoconus. Thank you. Thank you, Michelle.
Thank you, Stephanie, very much. It's a wonderful privilege to be able to be here again for the 5th time. This KeraClub was founded in 2016, and it was a joint initiative between Keratoconus Australia and the Safe Sight Institute. It's become a very important date on the calendar, and it provides a very unique opportunity for us all as keratoconics and their families and medical professionals and research bodies to actually get together and to inform all of us who are really interested not only in the lifetime of what this means as a keratoconic, but also the new initiatives and the research progress that is happening over time. Usually, of course, we run as a face-to-face meeting in the middle of Sydney, which is a wonderful theatre, and the Claffey Theatre the Safe Sight Institute manages to put on for us every year, which we're very grateful for. Unfortunately, this year, with everything running online due to COVID, it was obviously not going to be possible, but obviously still very important to be able to keep the support going. So we've decided to have this webinar tonight, and we're able now to be able to invite the wonderful panellists who have given up their time to tell us about different, not only initiatives, but also to keep us informed. It's important also in these times where we may feel isolated and we may feel worried about the general state of the world, but also about our own condition and the fact that COVID may be preventing us from being able to get advice from others. So tonight is simply about sharing more information and to be able to help us with any issues that may be affecting us. So thank you very much to our panellists tonight who are going to be discussing these things with us. Professor Stephanie Watson, Ms. Jessica Chi, Dr. Alan Arid, and Dr. Himal Kandal. I would now like to introduce Professor Stephanie Watson, but before I do, I am also very grateful to be a part of Keratoconus Australia. And we do engage in a number of activities to promote our primary objective of providing support to people with keratoconus and their families. So Larry is a great supporter and the president, and in this time it's especially important to keep communicating so we're not feeling isolated. So you can contact www.keratoconus.org.au, or you can give them a call. You'll find the numbers and the contact numbers on that website. So thank you, Stephanie. I will hand over to you. Professor Watson is the head of Corneal Research Group at Safe Sight Institute and the head of Corneal Unit at Sydney Eye Hospital. She's the chief investigator of the Safe Site Keratoconus Registry. She is known for her groundbreaking research in corneal therapies. Professor Watson is the chair of the Ophthalmic Research Institute of Australia and expert advises the 150 million stem cell therapies mission. She was awarded a New South Wales Premier's Prize, New South Wales Premier's Prize for Leadership in Innovation. She's a dynamic, incredible woman, and it's wonderful to have her support for the last 5 years to help run this event. She's always so enthusiastic and so supportive, and for that we're very grateful. Thank you, Stephanie.
Thank you, Michelle, for those kind words. Now, most of you with keratoconus know that you see the world in a different way, but you also have to live in a different way. Next. Next. And so my research program has focused on trying to improve the lives of patients with keratoconus. And this is through discovering new knowledge that may lead to new treatments, but also improving the current treatments that are out there and available at the moment. Now, my research group works very hard at trying to improve the lives of patients with keratoconus through this work, and we collaborate internationally across many countries. Next slide. Now, one of the areas that I've been interested in looking at is cross-linking. And cross-linking, as most of you may know, aims to stop keratoconus getting worse. But still, yet we don't really know how to define keratoconus getting worse. What is the best way to measure it? And we also don't really know what the best cross-linking method is. We know that the traditional method with the epithelium off is probably got the most evidence, but there's many new ways coming that might provide an easier procedure for the patient. And ultimately, we want to avoid complications. Next slide. So to try to answer some of these questions, I set up the Safe Site Keratoconus Registry, which has been running since October 2015. And the reason for a registry is because with a clinical trial, you can only look at very certain groups of patients with very strict inclusion and exclusion criteria, and certain treatments that are also specified in a very specific way. And often it takes a long time to get the trial up and running, and by the time the trial is finished, there are actually new treatments in the clinic. So I wanted to look at what was happening in the real world treatments and real world patients. Next slide. Now, the registry has a team of support staff, including researchers, IT professionals, biostatisticians, and we all work together to keep the registry functioning. Next slide. I thought I'd just give you an overview of some of the research that the registry has been producing. You'll hear more also later from Mr. Himmel Kandor, my postdoc in the Safe Site registries at the moment. But just broadly speaking, the registry provides outcomes data. So we have about 6,000 patient visits on the system with about 3,000 cross-linking treatments. And every year, the amount of data on the registry has been growing at about 35%. And I'll show you shortly the sort of information we get from that outcomes data. But clinicians, if you can go back, thanks. Clinicians using the registry are also able to perform benchmarking. So they can look at their practice and they can compare it to everybody else in the registry and see whether their practice is in line with what's happening elsewhere. And benchmarking has been shown to improve outcomes by ensuring clinicians understand the results of their treatments. And lastly, with the registry, patients can also see their journey. On this graph, which is produced after, whilst the patient is seeing their ophthalmologist or optometrist, you can track what's happening with the corneal shape and vision and whether there's any procedures performed. So on the graph here, you can see the declining lines showing reducing vision, and then cross-linking is performed, which has stabilized the vision and the corneal shape. Next slide, please. So recently, we looked at the 5 years outcome data from the registry after corneal cross-linking. And what we found is that there was a further improvement in vision over time, a further flattening of the cornea, and also a reduction in the long-term adverse events. over 5 years. Next slide. We then looked at, well, what are common adverse events? And probably the most common is haze. And haze has been said to occur in almost all cases, such that it's said to be a sign that the cross-linking is actually working. But when it's clinically significant, it drops vision. And so it's important that we understand who's getting the clinically significant haze so we can develop treatment protocols to prevent it. And what we found through the registry data, that it was younger patients with steeper corneas who were getting more haze. We need to counsel these patients that they're at risk and follow them closely and adjust the post-op treatment as needed. Next slide. The registry has also been useful to alerting us to what's happening to keratoconus care during COVID. These graphs show you dramatic reduction in visits to ophthalmologists and also cross-linking procedures since the pandemic began. It's of concern that patients may not be seeing their ophthalmologist or optometrist for keratoconus care, particularly if they're young and they're at risk of progression, because they may lose the opportunity for the cross-linking to stabilise their cornea. If their cornea becomes too thin, they may then not be eligible to have the procedure. Next slide. The other recent addition to the registry has been an optometry module. This is going to be quite useful because it will allow your optometrists and ophthalmologists to share the data about your eyes, and we'll also be able to audit contact lens outcomes. Next slide. So that's just a quick overview of one area of the keratoconus research that we're undertaking at the SaveSight Institute, and where it's led us to is that, look, using our real-world data, we can say that cross-linking is an effective procedure for preventing progression in the long term, and that there's positive outcomes, including some improvement in vision and change in corneal shape, and that those changes are actually sustained over time. And that using the registry, we can pick up the impact of other health issues such as COVID on keratoconus patients, and that's something we can work with Keratoconus Australia on, is making sure people are still receiving adequate treatment. In the long term, the cross-linking has a good safety profile with few late adverse events, but our long-term data is going to be further informed by the optometrist entering their data, as they're often involved in the long-term care. And our future work will look at the particular cross-linking protocols to determine which is best, such as to reduce the risk of clinically significant haze. Next slide. We've wanted to share our research findings with patients and their carers, and so we have produced a keratoconus newsletter titled Kera News, and we hope to produce a further edition soon. The current edition is available in print and also on the website linked below. Next slide. So I'd like to thank you all for attending, and then hand back to Michelle for further talks. Thank you.
Thanks very much, Stephanie, for keeping us informed and the updates on what's happening with this very valuable registry. And it's really exciting to know that the optometrists are coming on board as well with this now, the next stage. It's wonderful. And speaking of which, we would like to introduce our next speaker, Ms. Jessica Chi. She is the Director of iTech Optometrists and Independent Contact Lens Practice in Melbourne. So because of our COVID webinar, we're now able to have experts from other states as well. So we thank you very much, Jessica, for being here. This particular practice in Melbourne prescribes all forms of specialty contact lenses. She's the current Victorian and a past national president of the Cornea and Contact Lens Society, and an invited speaker at meetings throughout Australia and beyond. She's a clinical supervisor at the University of Melbourne, a columnist for My Vision, lead visionary for Sight for All's contact lens projectors, a member of the Optometry Victoria South Australia Sector Advisory Committee, and has obtained fellowships with the Australian College of Optometry and the British Contact Lens Association. So thank you. We look forward to hearing what you have to say tonight.
Thank you, Michelle, and thank you to Keratoconus Australia for the kind invitation. And thank you all for taking the time to listen in this evening And it's nice to see a lot of familiar names out there, so thank you for coming. So it's pretty interesting times that we live in, particularly here in Melbourne. And there has been a lot of misinformation and myths floating about. And what we understand about COVID is constantly evolving as our knowledge about this sneaky virus develops. But here are some facts that we, oh, sorry, next slide. Next slide. So here are some facts that we do know. The virus is spread from droplets from an infected person, either by person-to-person contact or touching a surface that contains droplets from an infected person and then touching your face. Fortunately, the virus is not frequently found in the tears, and whilst it potentially can be transmitted through the eye is actually rarely involved and is not the preferred gateway of entry. Conjunctivitis can be a complication, but it's quite uncommon, and and so far it's been reported in less than 3% of cases. So what can we do to prevent the spread of the virus? I'm sure we're all now familiar with these instructions. Thoroughly wash and dry your hands and don't touch your face. Rubbing your eyes with keratoconus is very much a no-no, and Alan will go into far more detail during his talk following. But now, even more than ever, it's more important as we really need to avoid touching our faces. It's also important to note that normal spectacles don't provide protection against COVID. And the other thing we need to remember is that the virus can live on plastics for a few days. So given that we often touch our glasses, particularly if they're not worn at all times, and especially for us in Melbourne, we may be frequently adjusting them due to glasses fogging up with mask wear. We need to be washing our glasses also on a regular basis. And this can be simply done with soapy water. Next slide. So in terms of maintaining good contact lens health, we need to make sure we maintain good contact lens hygiene. So what does that mean? It means thoroughly washing and drying your hands every time before we handle our contact lenses. It means sticking to the care solutions prescribed by your optometrist. Definitely don't try other things like water or your own spit. I know it's like the same body, but there's different bacteria that live in our eyes and our mouths, and they're not meant to live in the same space. So please don't lick your contacts. Tap water is also not sterile, even in a clean country like Australia. There's one particular bug in tap water that's really difficult to eliminate, called Acanthamoeba, which doesn't infect commonly, but when it does, is devastating and can result in blindness and even loss of an eye. Always use fresh solution. Don't top up or reuse old solution. And whilst it may be all well and good to wash your hands, clean your lenses, one of the main sources of infections is actually the contact lens case. So bacteria can form biofilm in the cases, and whilst your lenses are in there overnight, they can colonize onto your contact lenses. So make sure you not only clean, but replace your case on a regular basis. And don't overwear or overextend the life of your contact lenses. Follow your optometrist recommendation for replacement. The older the lens, the higher the risk of infection. It's always a good idea to have a spare pair of lenses or backup pair of glasses if glasses are an option for you, particularly during these times where movements may be restricted. And always remove the lenses if there's any discomfort, tearing or redness, and contact your optometrist if the symptoms don't resolve. And please also avoid showering, swimming and sleeping in your contact lenses. Next slide. So many of you may be heavily reliant on contact lenses, but rest assured there has been no evidence that contact lens wear increases your risk of catching COVID. As mentioned, good hygiene is absolutely crucial, not just in times of COVID, but in all times to reduce your risk of complications. It's also been recommended that if you are sick during these times, please cease wear. If you're not sure, don't soldier on and hope that it fixes itself. Take the lenses out and keep them out until your eyes have recovered to make sure that you're not making a potential problem much worse. Next slide. It's also important to make sure that you maintain your regular eye care during these times. For me, the best solution to a problem is to avoid it in the first place. So keeping up with your healthcare will help prevent future problems and potentially keep you away from needing emergency care. And please be assured, we are here for you. We are following strict hygiene and disinfection protocols to protect you, But we also ask you to alert us if you have flu-like symptoms or have been in contact with anyone who may be a suspected COVID case, to also help protect our community. And also, please be assured that our lens manufacturers are operating as normal. They've always had strict hygiene protocols, but they're taking extra precaution now, such as taking temperatures before entering work. And some are splitting into teams in case a team needs to quarantine. In Australia, we have 4 custom laboratories, which are fortunately located in all different states. But we also have access to many international laboratories. So we don't foresee any issue having access to your contacts. So far, the turnaround time for local manufacturers has been exactly the same as pre-COVID. And I've also spoken to the laboratories, and they're happy to extend warranties for patients who aren't able to get in to their appointments due to COVID. Next slide. And next slide. So I'll briefly talk about contact lenses. So many of you, as you're aware, contact lenses causes the cornea to thin, protrude, and become cone-like in shape, resulting in irregular astigmatism, blurry vision, halos, and shadows. Next slide. In the early stages of the condition, spectacles and soft contact lenses can be helpful. However, as the condition progresses, they may be of little use as they can only really correct for regular astigmatism. Next slide. As keratoconus becomes more pronounced, the rigid gas permeable or RGP contact lenses are needed to attain a normal level of vision. And this is because the RGP sits in front of the cornea and becomes the first refractive surface of the eye rather than distorted cornea. It's important to note that the RGPs don't push the cornea into shape, and they're there purely for vision. They're great in that they're fully customizable to your eyes. They're relatively inexpensive and they have an excellent ocular health profile. Next slide. However, those of you who have worn RGPs know that they do come with an adaptation period. The cornea is the most sensitive tissue in the body. So if you stick a piece of plastic in there, of course you're going to feel it. When you first begin to wear these lenses, when you blink, you'll feel them. However, this becomes less of an issue as you become desensitized to them. The adaptation period can be anywhere between days to months. Everyone is different, and some people may never get used to them. The other issue is that they can be prone to coming out of the eye, which never happens at convenient times or locations, like on the sporting field or on the dance floor. They can also be prone to having stuff underneath the lenses, so may not be ideal for windy or dusty environments, and sometimes may not center very well. But fortunately these days, for people who cannot get used to RGPs or when they are inconvenient due to work or lifestyle reasons, we have hybrid and scleral lens options. Next slide. A hybrid lens is rigid through the middle and soft on the outside, so you get the vision of an RGP lens, but also the comfort and stability of a soft lens. Next slide. A scleral lens is a larger lens which rests on the sclera, which has much less nerves than the cornea, and it does not touch the cornea as it completely vaults over it. It also shows very little movement in the eye. Next slide. They have similar benefits and similar downfalls compared to RGPs. The main benefit is that they provide much better initial comfort and rarely come out of the eyes, which creates far less stressful moments, but also means that they are rarely lost. They're also bigger, so if they are dropped, then they're much easier to find. And I can tell you, I've spent a lot of time crawling on my consulting room for trying to find these smaller RGPs. And there are some that have just completely disappeared. But if I drop a mini scleral or a hybrid lens, I don't think I've ever lost one of them, which is good. In addition, they both tend to center pretty well and provide a real viable option for people who are RGP intolerant. The main downfalls for these lenses for patients is that compared to RGPs, they're more expensive and they're also more difficult to insert and remove. However, because of this technology and cross-linking, many grafts have been prevented. I've worked with Keratoconus since I graduated almost 14 years ago, and In the past, I would refer off a patient for grafting probably every 2 to 3 months. But I find now I'm probably only referring off 1, maybe 2 a year. And that's because of these contact lenses and corneal graft surgery. I mean, don't get me wrong, corneal grafts for keratoconus are highly successful. But as one of my ophthalmology colleagues said very eloquently, it's better to have your own bits than someone else's bits. Next slide. So I'll leave you there. Thank you for your attention. Sorry that was a bit quick. There was not a lot to cover in a short amount of time. And remember, wash your hands and don't touch your face. Thank you.
Thank you, Jessica, very much for your informative talk. It's always good to hear about the different kinds of lenses and treatments available, but also really at this time to know that we can still go and visit our optometrists and that you are taking all of the precautions that are necessary for us to all stay safe. And obviously we can do our bit with that and not visit you if we are feeling unwell. I would now like to move on to Dr. Alan Ared. And Alan is a clinical optometrist who's working at the Omni Eye Centre. He's a PhD candidate at the School of Optometry and Vision Science. He graduated from the School of Optometry New South Wales class of '94, and he's been working in private optometry practices ever since. His rooms are in Kogarah in New South Wales. He's also received the distinction of hosting the longest talkback eye program on Australian radio with his weekly show airing for 20 consecutive years on Sydney's #1 station 2GB. He's currently undertaking this PhD, and it's also very, very good for us to have you talking about eye rubbing. It's often brought up over the last 4 years of our KeraClub meetings that we've had. I, for one, must say that I was a very severe eye rubber, and my 3 children have heard me more than once tell them to stop rubbing your eyes at night time. Sometimes I could actually hear my youngest son squishing his eyes so much it would go right through me. So I'm very interested to hear what you have to say, as I'm sure the rest of us are. Thank you very much, Alan.
Okay, good evening and welcome to KeraClub 2020. It's great to be part of a great group of panelists, and thank you all for taking time out of your busy schedules to join us. We'll go to the next slide. Oh, that's just a disclosure statement, which I think Ms. Michelle has already mentioned. Now, if you can't hear me, just write some comments and I'll try and speak a bit louder. The first slide is basically just something I just want to talk about, which is quite obvious, and that is, firstly, everyone rubs their eyes. Okay, so this is what we call normal rubbing. It's a common, natural, benign physiological response. We do it when we wake up, when we're in air conditioning or an artificial environment, in response to fatigue, irritation. So everyone at some point will rub their eyes. Now, what about rubbing in keratoconus? Not all eye rubbers will develop keratoconus, and equally or conversely, not all KC sufferers eye rub. So we have patients that come in that are keratoconic. You ask them, do you rub your eyes? They say no. But there's also a different form of rubbing known as passive rubbing, which we don't really understand. And this is where people may rest their face on their hand or sleep face down on a pillow. And this is where we call in family members and ask them, look, you know, do you see people lying face down? Do you see somebody, you know, resting their hand on their eye? And this is what we call passive rubbing. So in an attempt to try and quantify or differentiate the different styles of rubbing, we'll go on to the next slide. We have looked at the literature, and there's currently a gap in the literature. And there's no real way of determining what is a normal rubber versus somebody who abnormally rubs. Now, the ones who abnormally rubs tend to rub constantly, chronically, with force, with their knuckles, with their palms for, you know, many minutes, or, you know, quite often every day. Whereas those who normally rub, like I just spoke about, you know, are intermittent and just the ones that rub when their eyes are a little bit irritable. So what we've done, if we go to the next slide, is I have developed a questionnaire. And this has been, it complies with the Human Research Committee, the Ethics Committee at UNSW, which tries to narrow this gap in the literature to work out what is normal rubbing versus what is abnormal rubbing. How do we differentiate between the two, and how do we quantify the degree of rubbing? So what I'd like everyone out there to do is, if you do rub your eyes, please put your details down. We can get a copy of this questionnaire sent out to you. And it would be great if we could get you all to answer these questions, because it helps us learn more about rubbing behaviour. Now, it's difficult to systematize human behaviour onto a form, but currently that's all we have. We don't really have a lot of information about rubbing behaviour. You ask people how much they rub or when they rub, they often forget. But if you can fill in these questions, it will go a long way in helping us, as I said, understand more about rubbing. We'll go to the next slide. I want to spend a little bit of time about this, but I just want to take us back right to the very beginning about the cornea and about keratoconus. So keratoconus is the most common form of corneal ectasia. It's basically where an eye that's nice and round like a soccer ball turns into a witch's hat. And it happens at the cornea. Now, if you look at the cornea, it's very similar to our skin. Our skin has modalities of sensation that are sensitive to touch, to temperature change, to tickle, to itch. However, the cornea has predominantly pain receptors, and there are more pain receptors in the cornea per square millimeter than any other part of the body. So when I first started researching, we go back a bit, yeah, just back one slide. When I first started researching eye rubbing and keratoconus, I looked at the cornea, and here we have a structure that rejects everything. It hates everything. Okay, so whether it's a speck of dust, an eyelash, a puff of air when we're checking tonometry or eye pressure. So no matter what you bring near the cornea, it rejects. But the moment you press the eyelid from the outside against the cornea, not only does the cornea accept the inner part of our eyelid, it's actually a feel-good sensation to press against the eye. So why is it that the cornea rejects everything, but it allows the inside of our eyelid to be pressed up against it? So when I started studying this, I tried to work out what these neural connections were to allow this sensation to occur. So let's look at the anatomy of an eye rub. Let's just look at what happens when we rub our eyes. So electrical signals travel from the motor cortex of our brain down through the muscles of the arm, through the muscles of the hand, through to the muscles of the fingers or the knuckles and the palm to create the rubbing motion. But a copy of these signals goes back to an area of the brain called the cerebellum. And it's the cerebellum that transforms these signals into inhibitory signals, which basically shuts down this sensation that the cornea has. And this is one of the reasons why people who rub their eye do not feel or aren't aware that they're doing any damage to their cornea, because they don't feel anything. It's actually therapeutic for them to rub. Okay, so that's one of the things that has come out of the study, and that's why a lot of people who rub they don't really realize that they're doing much damage to their eye because they don't feel that they're doing any damage. The conjunctiva, on the other hand, has more receptors to itch. So when people say, oh, my eyes are itchy, it's usually the receptors in the conjunctiva that are creating ocular itch. But it's the receptors in the cornea that are sensitive to pain, which is why you can't, you know, it's very difficult to fit somebody with a contact lens, or, and that's one of the reasons why people rub their eyes. So we'll go to the next slide. And this is why I asked the question, you know, what makes people rub their eye? And there are many reasons. Dry eye, if you're working in an office, the eyes are itchy. You may have an unstable tear film. There are congenital disorders like Down syndrome. But the most common answer that I get from patients why they rub their eye is because it feels good. Okay, so it stimulates biological reward. It activates a pleasure center. We know that if you press against the eye for long enough, the vagus nerve, the 10th cranial nerve, is activated, and that lowers blood pressure, reduces anxiety, and it makes people feel good. Now, there was an interesting study in the Journal of Ophthalmology in 2018 from Greece by Moskos, which looked at the depressive symptoms in a keratoconic group compared to those who were normal. And the patients who were keratoconic ended up having a greater score in their depressive symptoms versus those who were normal. And we know that people with keratoconus, they have troubles with glare, with halos, with blurry vision, distorted vision, and so on. So that's one of the reasons why they were slightly more, they scored slightly more higher in these depressive scores. But at the same time, they rubbed their eyes, which made them feel better. So rubbing their eyes makes them psychologically feel better, but worsens their disease process. So it was like a double-edged sword. So the take-home message is don't rub, and if you are experiencing depressive symptoms about your eyesight, then you do need to talk to somebody about that. We'll go on to the next slide. So what actually happens when the eye is rubbed? And we'll go through these really quick. Now, these are some of the measurable parameters that are in the literature. One, there is a reduction in corneal epithelial thickness. There is an alteration to the surface regularity and the symmetry of the cornea. There's a reduction in tear film breakup time. The next one, the corneal curvature is obviously flattened. This thing here, change of lower corneal, lower order aberrations. I'm going to talk a bit about that later. But basically, aberrations are imperfections in the cornea which induce light scatter. And there's also a change of astigmatism. So these have all been published in the literature as changes to the cornea that are measurable parameters that can happen after an eye has been rubbed. We'll go to the next slide. This paper looked at rubbing in normals versus those with keratoconus. And if we go to the next point, the keratoconic group showed a significantly greater change in what we call anterior chamber volume, IOP or intraocular pressure, and corneal posterior astigmatism in the group that were normal controls. So, why are some corneas more vulnerable to rubbing trauma than others? And I think it's a case of genetics loading the keratoconic gun, but the eye rubbing pulling the keratoconic trigger. So if mum and dad have keratoconus, or people in the family have keratoconus, and you're out there rubbing your eye, you are more than likely to develop keratoconus by virtue of your genetics. And there is a form of keratoconus which is called semi-keratoconus. Others call it subclinical or form fruus keratoconus, which is a type of keratoconus that starts and then stops. And we see that when we do our corneal topography, which is a measurement where the front of the cornea looks pretty normal. Patients are corrected to 20/20 or 6/6 perfect vision. through spectacle correction, but they come in complaining. They can come in complaining of glare and halos and headaches, and their vision is a little bit blurry. And every time people check them, their glasses are fine, but no one has really been able to work out what their problem is until you actually do corneal topography on these patients and you work out that they have subclinical keratoconus. So again, it's a case of genetics and the environment. If there's a family history of keratoconus, you're more likely to get it if you rub your eye. So again, don't rub. Next slide. Now, short of absolute proof, and I can pluck numerous publications from the literature, and you know, whether they are case reports or hypothesis-driven experiments or systematic reviews, you know, there's a whole bunch of articles out there in the literature. There is strong evidence out there that demonstrates that if you rub your eye, you will not only go from being normal to a keratoconic eye, but if you have keratoconus, you will worsen the disease process. And as I said, there's a lot of literature out there, and this is just a snapshot of some of the studies that have been published. Next slide. So, what is my research doing and what are some of my research aims? Well, the first part is just basically a repeatability of some of the instruments that I'm using. One is an OCT, which is an anterior segment OCT, looking at the thickness of the corneal epithelium. Another instrument I'm using is called an Oculus Pentacam. If we go to the next point, and we're looking at some of the corneal parameters that change before and after rubbing. So this is corneal epithelial thickness changes, densitometry, which is a measurement of corneal transparency, intraocular pressure, and also corneal curvature. And then the third part of the study is the questionnaire that we've developed, and it's called an association-based study to see exactly what's happening to these patients who are rubbing, who are chronically rubbing for a long period of time, and how their disease is changing over the years. Next slide. So the first three stages of my work has been complete. We are now recruiting participants who are known eye rubbers that have keratoconus who would like to participate in these particular studies. So what it involves is doing a whole bunch of screening diagnostic tests, getting them to rub their eyes in the way and the manner that they would fill in the questionnaire. So if you're using your fingertips, for example, or your knuckles or your palms, you would rub in that same manner. And then we would take measurements after rubbing, shortly after rubbing, and look at changes in these corneal parameters after rubbing as well. Now, the entry criteria is, we'll just go back, is that we're only accepting keratoconics that have not had any form of corneal surgery. So no LASIK, no cross-collagen linking, no corneal grafts, no layered grafts, just pure keratoconus. It's okay to be a contact lens wearer, but no corneal surgery as the entry criteria. Next slide, and we'll quickly go through this. In terms of corneal epithelial thickness, I'm looking at 5 different areas. The vertex, if we keep clicking, yes, that's right, the center of the cornea, and then 3 millimeters away from center, superior nasal, inferior, and temporal. Some of the preliminary results are on the next slide. Here we go. So roughly 50 microns of corneal epithelium is the measurement in some of the keratoconic eyes that has been measured by the Triton anterior segment OCT. If we go to the next slide, and if we click once again, we had one participant that had an 18 micron reduction in epithelial thickness after rubbing, and also at the position of 9 o'clock. So obviously with more participants, we're able to gather more information and put all this data and statistically analyze them in a way that is in line with our experimental aims and hypotheses. Next slide. Now, corneal densitometry. Now, this is what I was going to talk about before in terms of corneal aberrations. Now, this is a measurement of how well light enters the eye. So the cornea, as I said, is a very complicated structure. The corneal collagen has to be organized in such a fashion that the light entering the eye has minimal scatter. And that improves definition, contrast, visual acuity. The moment you start to play around with the way the organization of these corneal fibers, then light will scatter and the reduction in contrast is evident. And these are the people coming in saying that they can't see black on white, it's gray on white, it's very hard, eye strain, headaches, you know, they start complaining of all these things. So the way we measure transparency is by the Oculus Pentacam, and we use a software program in the Pentacam called densitometry. And in terms of my study, I'm looking at 4 separate areas: the central 0 to 2 millimeter zone, a donut around that between the 2 and 6 millimeter zone, and then at 2 separate depths: the anterior 120 microns and also the center layer. If we go to the next slide, the corneal densitometry is measured in grayscale units. The lower the number, the more transparent the tissue. The higher the number, the more opaque the tissue. And what we're finding is that patients who rub their eyes tend to have more, tend to have a higher densitometry reading immediately post-rub. And the ones that are keratoconic are showing even greater change than normals. So this is all preliminary data. We're still recruiting participants to complete this particular study as well. Next slide. And this is just some of the change immediately after rubbing and 5 minutes after rubbing. What I found is that 1 minute after eye rubbing, the cornea almost returns back to baseline. 5 minutes is a little bit too long. So we don't really need to repeat these measurements 5 minutes after rubbing. We'll go to the next slide. So like I said, I'm just breezing straight through these because we're limited by time. Why are we doing all this? What is our prime directive here? And if you look at the bottom left-hand photo, that is a normal cornea. And our main aim is to stop a normal cornea from transforming into a keratoconic cornea. So how do we modify behavior? Quite often what I do is I show patients these photos and I tell them, if you keep rubbing your eyes, it will turn from having a nice round soccer ball into a conical shaped cornea. I will show them topography. And corneal topography is very, very critical in terms of demonstrating to a patient what a normal cornea looks like versus what a keratoconic cornea looks like as well. Prescribing eye drops, shutting down the chronic low-grade inflammatory process that is common and notorious in keratoconic sufferers. So this includes prescribing eye drops such as mast cell stabilizers, antihistamines, or anti-inflammatory eye drops. There is a new eye drop that has just come out that has been approved by Special Access called Sequa, topical cyclosporin, which I love. It doesn't have the side effects of the topical steroids. I quite often put keratoconic patients on topical cyclosporin to help shut down these inflammatory processes in their tear film. Proper fitting contact lenses. Often keratoconics come in, their contact lenses don't fit too well, they may rock on the eye, they irritate the eye, and often these patients take their contact lenses out and their eye is so irritable that they just need to give it a good rub. So if you're out there and your contacts aren't fitting well, see your optometrist, see your contact lens specialist, get your contacts fitting a bit better, and that will also help reduce your abnormal rubbing behavior. Now, one of the other things, and I'll finish up real quick, is allergy testing. And I find it very surprising that many doctors, optometrists, GPs, ophthalmologists do not do routine allergy testing when a patient is first diagnosed with keratoconus. And these are simple blood tests. There's a RAST study, total IgE study, or even a skin prick study. Because if you know what you're allergic to, then you know what you need to avoid. And that could be dust, certain grasses, pollen, mold, pets. So if you know what to avoid, then at least it reduces your exposure to what could potentially be aggravating the ocular surface, causing people to rub. And regular eye exams, because we now have a software in the Oculus Pentacam, which tells us how a cornea is progressing over time. It's called the ABCD Bellin-Ambrosio display, looking at the anterior radius of curvature, posterior radius of curvature, minimum corneal thickness, and best corrected visual acuity. And if we can do these tests over a period of time, we are able to better identify those keratoconics who are progressing. So, golden rule right at the end, no rub equals no cone. And I'll hand you back to our moderator. Thanks for listening.
Thank you very much. That was incredibly informative, and it sounds like you've got your work cut out for the next little while with all of these amazing amounts of research. It was really informative, and I know there's a lot of us that will be thinking and benefiting. And also, there were several questions coming through. So just a reminder that if people would like to ask questions, if you want to type them in the Q&A section at the bottom of your screen, we'll try to deal with as many of these as we can. We are running sort of fairly low on time, but we will be dealing with the priority questions as soon as we can. I'd now like to pass you on to someone who's been incredibly constructive in getting tonight really going and helping with every ounce of the organisation. Dr. Himal Kandal, he has published several research articles in reputed journals and won several awards for his academic excellence. He received his PhD in 2018 from Flinders University with the Vice-Chancellor's Prize for doctoral thesis excellence. In that same year, he was awarded with the International Student of the Year by the Governor of South Australia. So thank you.
Thank you, Michelle. Professor Watson has already highlighted the importance of research at safe-site keratoconus registry. Having a large amount of data from keratoconus patients enables us to conduct research to better understand keratoconus and research that helps clinical decision making. Today I will share with you some key messages from our recently published papers in the reputed journals. I will try to be very quick and just highlight the key messages. In the first study I'm going to present, we looked at the quality of life impact of keratoconus and found that although a person's overall day-to-day functioning is determined mainly by the better eye, the vision in the worse eye may influence the quality of life and well-being. So clinicians should keep this in mind when treating keratoconus patients. From this second study, in this study, we reviewed all the registries available in ophthalmology, and the review highlighted the benefits of adopting disease-focused, good quality registries in clinical practice. We showed that a registry can drive improvements in patient care. In this third review, we analyzed data from nearly 12,000 keratoconus eyes which had no treatment. We concluded that closer follow-up and lower threshold for cross-linking should be adopted in patients younger than 17 years and with stable corneas. And to tell if keratoconus is getting worse, clinicians should monitor corneal shape. In another study, we looked at what was the impact on work patterns when we implemented safe-site keratoconus registry in the hospital setting. Safe-site keratoconus registry could be used easily in clinics, allowing improvements in patient care to be made. In next study, this is again a review paper. We evaluated the existing evidence on quality of life impact of keratoconus. As quality of life improvement is the most important outcome, we also assess the quality of the tools to help clinicians decide what to use when. When it comes to measuring quality of life, it's obviously not as easy as measuring length or weight or height. So it is more complex, and clinicians often don't have that information what to use. So our review would help the clinicians to make appropriate selection. In this review paper, we found that Keratoconus outcome research questionnaire was the most scientific and instrument which had robust measurement properties. And this is the questionnaire we are using in our SafeSite Keratoconus registry. And in the next study, we then evaluated whether the questionnaire was working well in our registry population, and the questionnaire was working really well. And the study findings suggested the continued use of Keratoconus outcome research questionnaire to routinely collect, measure, and monitor quality of life data in keratoconus patients. So now we'll go to question and answers.
Thank you, Himal. I've just been looking through the questions, and there's a great range of questions there, which is excellent to see. And just having a look through there is one common theme there around swimming and contact lenses. And I wondered if, Jessica, you could provide some comments around that. Should you do it? How to best reduce your risk, and why not swim in them?
Well, it's one of those things where infections like acanthamoeba really are rare, but all the infections from acanthamoeba are to do with water, and it's an incredibly difficult bug to treat. And the treatment for it is basically putting full cream into your eyes for months. And it's not one of those things we see commonly, but it's like I say to patients, it's about reducing our risk. So I could jaywalk every day and not get hit by a car, and probably won't. But then if I do get hit by a car, then I know why I got hit by a car. It's because I jaywalk. Though, like, I'm a contact lens patient myself, and I know what it's like to not be able to see. So if you are going to swim in your lenses, if it's in the pool, definitely tight-fitting goggles. It doesn't work in the surf. Making sure that you take your lenses out immediately after swimming, and cleaning the lenses, and re-lubricating the eyes, and making sure that if they're uncomfortable, you leave them out for the rest of the day. It's all about reducing our risk. And I mean, the best thing would be is if you could see without your lenses, but unfortunately that's not an option for a lot of you.
And in terms of sort of relative risk, because there's, you know, swimming pools, ocean, spas, fresh water, or do you think that, you know, in terms of judging relative risk, or is it all sort of the same?
I actually don't know about that. I would think maybe spas and saunas are a bit higher risk because of the extra heat, but I mean, you'd probably know better than me, Stephanie.
Yeah, it is an extra risk being in a spa for acanthamoeba and fresh water as well. In England, there's a lot of acanthamoeba, and I think that's to do with the water system there.
Yeah, I mean, I don't know if you recall, but probably about 15 or 20 years ago, there was an outbreak of acanthamoeba somewhere in the States. I think it was Chicago. And a lot of the people that had the acanthamoeba weren't even contact lens wearers.
Okay. I think Jessica may have, are you still there? Another question that came through was just on cross-linking, and you know, what's sort of the best way to do cross-linking and what the evidence is. At the moment, most of the evidence suggests that epithelial off cross-linking is the most effective. Epithelial on has been shown to not be as effective. People are looking at different ways to do epithelial on to try to make it as effective as epithelial off, but in general, the off is the most effective. And then of that, you then look at using short or long techniques, and probably short and long are probably about the same in terms of being effective. People are looking at even shortening it further, and for that now oxygen's being considered, but we still don't know enough. Now, Alan, there was a question as well about eye rubbing. There's been quite a few about that, and people were wondering, look, how much, you know, keratoconus is due to eye rubbing. Sometimes when I see a patient with keratoconus and I say, look, do you rub? And they say no, or if they do, they then might feel guilty that they've kind of cause the keratoconus, but is there any proportions that, or percentages that we can say to people, look, eye rubbings cause this much keratoconus, or do we have to wait to the results of your research? Oh, Alan, you're on mute, sorry.
Okay, here we go. Okay, so this is one of the reasons why I was mentioning there's a gap in the literature with regards to normal versus abnormal rubbing. So the normal rubbing is what we all do. The abnormal rubbing is what we're trying to, I guess, differentiate and quantify. But there's also that subset of rubbing that we don't fully understand, which is the nocturnal rubbing. The patients that are sleeping face down, the patients that are resting their head against their hand. So all forms of rubbing will involve an exertion of outside pressure onto the globe. And it doesn't matter what style of rubbing it is, whether it's fingertips, knuckles, it's any form of exertion of force from the outside in, because that will also increase the intraocular pressure from the inside of the eye out. So at this point in time, because we haven't been able to quantify the various degrees of rubbing and the abnormal rubbing, we can't really answer that question. So I often ask other family members, and I call them the rubbing police, to look at the keratoconic sufferer, to watch them how they sleep. Do they sleep face down? Do they rest with their head against their palm? Because they may sit in the consulting room chair and say, I've never rubbed my eye, but then they're sleeping face down. So for them, we have to give them goggles when they go to bed, or wearing a mask, just to prevent that external force from pressing against the eye, because they're coming in every year and their keratoconus is getting worse.
Thanks. Himal, just in terms of quality of life, it might be of interest for people to know which areas are sort of most impacted that you found through the cork.
The cork measures the two aspects of quality of life, activity limitations and symptoms. And we have also added items on measuring eye rubbing, which is going to be a new thing, and which is going to be a useful, provide useful information. As Alan is saying, like there's lack of literature, probably there is lack of tool that can measure the extent of rubbing and that kind of thing. So our registry data will definitely help fill that gap as well. So when it comes to what we are measuring at what evidence we have until now, it's mainly like the distance vision activities are more impacted in keratoconus than the near vision activities. That's what we have found so far, but we still have to do more research and analyze data in more depth. Yeah.
Right. And then maybe this is a sort of, we are running a little bit over time, but it might be interesting to hear from each member of the panel as to what they think is sort of coming in the future for patients with keratoconus in terms of treatments or solutions. Jessica?
Well, obviously being a contact lens practitioner, there's always more and better contact lenses. I mean, our ability to measure the eye now has led to way better design. So we're much more able to more accurately fit the lenses, but there's also a lot happening in the space of working out how to reduce higher order aberrations. So even with contact lenses, some patients still experience distortion. And there's a lot of wavefront technology that's coming that we'll probably be able to incorporate into the lenses in the very near future.
Alan? Yeah,
no rub equals no cone. Very simple. So try and not rub. The other thing is, and just further to what Jess was just saying, we can now take a corneal topography measurement, put it into a program such as iSpace, for example, which basically recreates the surface of the eye, almost like taking an impression mold. And we are better able to fit a contact lens that is custom made to that cornea in a much better way than we ever were able to do so empirically. So better fitting contact lenses will reduce the effects on the cornea that, say, an empirical contact lens will currently does.
Himal, any?
Looking at the safe-side keratoconus registry and looking at the data and the data coming, I feel like more advancement in cross-linking types and more data, more evidence to support like new treatments. That is the biggest thing that is going to happen, and I'm very glad that we're like being part of this registry. We're able to contribute in that area.
Thank you. And so, you know, from my point of view, what I would like to see and what we're working on is sort of measures and ways to assess keratoconus that are meaningful for patients. So at the moment we have a lot of technical ways of doing that, but I would like to link that into things that will actually make a difference to people's quality of life. So not only do we understand corneal shape, but we understand why people are struggling with the different aspects and impact of the disease on their life. I think we need to understand better the mechanisms that cause keratoconus, and we have some lab work going on looking at possible underlying mechanisms, including UV, so we can actually stop people getting it. Then we need to actually capture the keratoconus before it progresses. And so that is also looking at better ways of picking up progression, and hopefully with some of the registry data and imaging data and also patient information, we can detect progression earlier so people can benefit from cross-linking. And then we need to continue to assess current treatments. Now, most of the treatments for keratoconus at the moment are sort of, you know, a sort of one size fits all in terms of surgery. There is some customization emerging for some of the treatments, but particularly corneal cross-linking, you know, could be customized to try to achieve better outcomes and also reduce adverse events. But most importantly we need to continue to understand what patients need from our research and what they need from our treatments. And that's what I think we need to focus on. Now, I'm going to hand back to Michelle for some closing words. And thank you all for participating.
Thanks, Stephanie, and thank you so much to each one of our panelists who have just been amazing tonight. The support that I feel as a keratoconic person is just wonderful, and I'm just really grateful that there were so many of us that were able to participate tonight and to be able to gain from all of the research, but also the support that we can feel. There are a lot of questions still coming up, I think, so that will be definitely dealt with afterwards, and there will be a survey for people to fill out as well that will be sent to you. So thank you so much, Stephanie. Thank you, Jessica. Thank you, Alan. Thank you, Himal, for contributing to tonight and to making this a continued event that I think that we will all benefit from, and especially this year with COVID, with all the concerns that brings. It's very easy to have a particular health issue like keratoconus that can actually make that seem insurmountable to get through what the impacts that can be with high-risk patients as well. So thank you very much to each and every one of you. Thank you to everyone that was a part of tonight. And stay tuned for further either webinars or hopefully face-to-faces. And it was great that people could join us from other states. And I guess that's the benefit of being able to put this on tonight. Thank you, everybody.
Thank you, Michelle, and thank you, everybody. Have a good night.